My name is Mohamed Alkhouli. I'm an interventional cardiologist at Mayo Clinic in Rochester. I'm pleased to be with you today. We're going to discuss the utility of transcatheter edge-to-edge repair in patients with cardiogenic shock. Cardiogenic shock mortality has not really decreased substantially over the last couple of decades. Lots of interventions have been proposed to reduce that mortality, which almost gets closer to 50% in the short term. And then a lot of those patients are now recognized to have significant mitral regurgitation. So the study was prompted by the fact that, well, we have high mortality, in cardiogenic shock patient, we haven't been able to improve that a lot, and a good proportion of those patients have significant mitral regurgitation. So what if mitraclip, in this case, or transcatheter edge-to-edge repair as a category, would be able to help reduce that mortality? So we're limited by observational data, right? There will be some randomized trials coming up, but we wanted to get the best source of data that we could possibly get to answer this question. We have something called the ACC TVT STS Registry in the US, which encompasses all of the cases that are being done as far as transcatheter edge-to-edge repair. So we wanted to utilize that data to focus on patients who underwent the procedure and had cardiogenic shock. And we queried the TVT STS registry, and we were able to find 3,800 patients roughly who met the criteria of cardiogenic shock. One of the challenges is we don't have a control arm. So we have patients who underwent the procedure and were defined to be in cardiogenic shock. So without a control arm, what we did is we used procedural failure as a control arm. So if a patient undergoes the procedure and it's successful, we could say that they were treated with edge-to-edge repair. And if the procedure wasn't successful, they would have not been adequately treated, and that would be the control arm. So that we divided the cohort into those who had device success, defined by a reduction in mitral regurgitation of at least 1 grade, with a final grade of moderate or less. And the second group would be the device failure who did not meet that criteria. And then we compared their short-term and 1-year outcomes. Yeah, so the main finding is the edge-to-edge repair procedure was able to reduce mitral regurgitation significantly, meeting the device success criteria in about 85% of patients, which is very promising to start. And then at 1 year, patients who had successful procedures had a substantially lower mortality after risk adjustment compared with those who had device failure. The absolute risk reduction was almost 20%, and the number needed to treat is between 4 and 5. So there was a lot of reduction in mortality. Obviously, this is an association. We don't know if it's a causation or not, but there was an association between successful MR reduction in cardiogenic shock patients and improved 1-year outcomes. Yeah, so this is, I would say, mostly hypothesis generating because we are using observational data limited by what we are able to collect in the forms in the registry. But it does raise the point that, we should pay a little bit more attention to those patients who are presenting with acute presentation to the hospital and have significant mitral regurgitation. Maybe the mitral regurgitation in this case, in their case, is not an innocent bystander. And maybe if we are able to reduce that regurgitation in a safe manner, we will be able to improve their outcomes. So really, it's a hypothesis generating that edge-to-edge repair might be useful in this population. And then it prompts us to design prospective trials that randomize these patients to interventions versus no intervention. Yeah, so there is a trial called MINUS trial that will randomize patients similar to the population we have in this study to edge-to-edge repair versus medical therapy. And we hope that that trial will inform the community further about the role of edge-to-edge repair in this population. I think more studies, even observational, would be welcomed. One thing that I would like to mention here is that the definition of cardiogenic shock is sometimes kind of elusive. A lot of efforts have been put into having a uniform definition of cardiogenic shock. In registry data, that's kind of challenging. So in our study, what we did is if the patients were coded to have cardiogenic shock in their data collection form, or if they received inotropic support before the procedure, or if they had mechanical circulatory support, we considered them to have cardiogenic shock. Now, that's the best we could do within the limitation of the database available. But I think future studies will dive a little bit deeper into the physiology and collect a lot of, biomarkers, hemodynamic information that would further inform us about the role of the therapy in cardiogenic shock patients.